Hello, my name is Daniel Kavlivsky from the Mount Sinai School of Medicine in New York City. I'd like to cover some of the basics about malaria. Here on this screen, you're seeing several names of causative agents of malaria. The most important name to remember is Plasmodium falciparum. Plasmodium falciparum is the cause of the worst type of malaria and responsible for most of the deaths. Plasmodium vivax and ovale are interesting because they can form a relapsing type of malaria, even after patients have been treated for the blood phase. Plasmodium malaria can cause malaria, but generally is less severe. And Plasmodium knowlesii is known as monkey malaria because it's not really a human pathogen. However, certain cases have been described in parts of the Southeast Asian parts of the world. On the screen, you're also seeing some pictures of the different parasites in the peripheral blood smear, as well as the mosquito Anopheles that transmits the disease. The global distribution of malaria emphasizes the fact that many cases are focused in sub-Saharan Africa. This also overlaps with the deaths from malaria, most of which are caused by Plasmodium falciparum, and many of which are in children under 5 years old. So remember, Plasmodium falciparum is the worst type of malaria. All species of malaria share in common a life cycle that looks fairly complicated. But for our purposes, let's focus on what happens in the human. When Anopheles takes a blood meal, she injects some sporozoites into the bloodstream. This form of the parasite is the target of the malaria vaccine. These parasites rapidly head to the liver, where in all types of malaria, they develop into a schizont, a tissue schizont inside the liver cell. At this point, the patient still doesn't have any symptoms, and we consider this the incubation period. These cells lyse, and eventually the merozoites go on to infect red cells. They develop into ring phases, sometimes mature trophozoites and schizonts, and these bags of parasites will eventually rupture open, releasing new merozoites. Those can go on to infect other cells, and this is around the time that humans become symptomatic, with fevers, chills, muscle aches, etc. Some of these parasites can actually develop into a sexually reproducing form of the parasite that's taken up by the next mosquito, and that continues the life cycle. If we see some of these gametocytes, it helps us to identify the species of malaria. Let's go through some cases just to show you some examples. A 45-year-old UN employee returns from a 6-week visit to his home country of Nigeria with fever, headaches, dark urine, renal failure, severe anemia, and icterus. And icterus you can see up on the upper part of the screen in the sclera. The yellowing in the eyes is from bilirubin that has been released by the lysed red blood cells. And here in the image, you can see that there are several parasites infecting multiple red cells. So the likely diagnosis here is going to be Plasmodium falciparum, based on the fact that we are dealing with multiply infected cells and a patient who's presenting with severe symptoms, including renal failure. The treatment varies, but for most severe malaria cases, we want to be using intravenous antimalarials, including artesunates. And in the United States, we also substitute IV quinidine instead of quinine, along with doxycycline or another second agent. For Doctors Without Borders, this case is very interesting because this is a 35-year-old woman who was a physician working for MSF in the Democratic Republic of Congo for 11 months. She reported having 3 bouts of malaria while there, and each time she was treated with artesunates. Her last episode of malaria occurred 3 months prior to return, and on return, a malaria screen was negative. 2 weeks after her return, she developed fevers around every 48 hours, chills, body aches, and headaches. She felt sure it wasn't malaria because during her previous episode she felt much worse. However, as we look at some of these smears, we will see that there are in fact infected red cells with not just the ring forms, but also some schizonts. Now, the schizonts are typically not seen in Plasmodium falciparum because those are kind of adherent to the cells, the endothelial tissue, in the small capillaries. So to see circulating schizonts usually is a sign we're dealing with some non-falciparum malaria. In fact, some of her cells that are infected are enlarged, and there are some finger-like projections that you can see that suggest that this, in fact, was a Plasmodium ovale case. So again, the first patient who had severe malaria, that was Plasmodium falciparum. It's transmitted by Anopheles, and it causes the worst type of malaria, including fatal infections. If we see a banana-shaped gametocyte on the peripheral smear, as you see in the lower right part of the screen, that's very helpful, but they're very difficult to catch. But when we see multiply infected red cells and heavy parasitemia, that's usually a clue that you're dealing with Plasmodium falciparum. The second case, as I mentioned, was Plasmodium ovale. Now, Plasmodium ovale and vivax both have a hypnozoite form, a dormant form of the parasite that in the liver can later become active and begin to divide in the blood. It's important to remember because the blood phases of the parasite, which are treated with typical agents that we use against malaria, are not necessarily going to be killed with the blood active drugs. So we need to use primaquine to kill the hypnozoite form after patients have been treated with chloroquine, most typically, for Plasmodium vivax and ovale. So to remind you about that peripheral blood smear and its point of diagnosis in the cycle, the sporozoites again enter when a mosquito takes a blood meal, and then they head to the liver. In all different species of malaria, this occurs. But in Plasmodium vivax and ovale, we will find that there is a relapsing hypnozoite form that can later cause disease. And sometimes that incubation period could be weeks or months. In the human stages in the peripheral blood smear, we're typically going to see the rings. But in vivax and ovale, we might see some of those schizonts or gametocytes as well. To make a diagnosis of malaria, it's important to remember that automated cell counters, while they can count the white cells, platelets, and hemoglobin and red cells, they're not able to distinguish intracellular parasites. So when you're looking for malaria, you have to ask specifically for thin and thick smears. The thin smear gives you much better morphology, but the thick smear gives you a little bit of a higher sensitivity. The thin smear is basically pushing one drop of blood across a slide, while the thick smear is created by adding a drop of water to a drop of blood and lysing those red cells. We now have additional options for diagnosis, including RDTs, or rapid diagnostic testing. Binax Now malaria is an example of one of these cards, which doesn't require a microscope, electricity to run the microscope, or an expertise in microscopy. So it's very useful in many parts of the world where many of these resources may not be available. So the big points about malaria basics are Plasmodium falciparum is responsible for the most severe malaria infections. Plasmodium ovale and Plasmodium vivax may relapse because of the hypnozoite. And malaria can be missed by automated cell counters, so remember to specifically ask for a malaria peripheral blood smear with thin and thick smears. I hope this has been a useful introduction to malaria the basics.